Hello and good evening, good day to everyone. It's Friday evening, and I'm very happy to be back here once again with everyone right here. It's going to be definitely an interesting session. Today's topic is definitely intriguing, but it's also really, really interesting. I know that we will have a nice session already. So let me just remind everyone that our topic is non-invasive PGT, and we have our very special guest who will explain how it all works. This is Estefanía Montoya, and she is the geneticist at Vistahermosa Clinic, which is located in beautiful Alicante. So hello, Estefanía, how are you feeling? And thank you so much for joining us tonight.
Hi, Caroline. Good evening to everyone. It's nice to be here.
Glad that we were able to invite you here, and I'm glad that you agreed to present this topic. And of course, as always, we will start with the presentation, but afterwards, as always, there will be time for your questions. So remember, you can put those in the chat section, and Estefanía definitely will help you out with all of those. And well, I guess let's get going with our topic. Okay, so I will put the presentation right here for you. So of course you can go ahead and yeah, let's do this.
Thank you, Caroline. Well, first of all, I thank you, Caroline, for inviting me to this webinar. As you said, I'm Estefanía Montoya, clinical geneticist at the genetics unit of Unidad de Reproducción Vistahermosa in Alicante. And I'm going to talk about non-invasive preimplantation genetic testing. Can we forget about an embryo biopsy? Before I start talking about non-invasive PGT, I think it's important to understand first some concepts. Let's start with in vitro fertilization process, or IVF, that it's a type of assisted reproductive technology that implies the combination of eggs and sperm in the laboratory. Among art techniques, IVF it's a complex one. There are different situations in which IVF is indicated. For instance, in case of advanced maternal age, when there's low sperm count, problems with ovulation, or when simpler art techniques have failed, such as artificial insemination. There are two types of IVF. The first one, it's a conventional IVF that consists of placing the sperm together with the egg in a laboratory dish. The second one is the name intracytoplasmic sperm injection, or ICSI, when the sperm is directly injected into the egg and is used when the chance of fertilization is low. If the fertilization process has been successful, the fertilized egg starts dividing, as we can see in the images, and it becomes an embryo. Embryos are cultured in an environmentally controlled chamber in the laboratory and are regularly checked by embryologists to make sure they are growing properly. Within about 5 days, a normal embryo has several cells that are actively dividing, and at this stage, the embryo is named blastocyst. Then, best embryos are selected, and they can be vitrified to be used later, or usually only one of them, the best one, is transferred to the maternal uterus. This is usually on day 5 at the blastocyst stage, although it can also occur on day 3. This selection is made based exclusively on the embryo morphology that takes into account parameters such as number of cells, cell size, or fragmentation. Nevertheless, embryo morphology is not always related to chromosome composition, And at this point, the need for a genetic testing is in the embryo appears. Human cells have 46 chromosomes that are the structures that contain our genetic information, our DNA. Half of them, 23, have been inherited from our father, and the other half from our mother. We say that an embryo is euploid when all cells contain 46 chromosomes, and an euploid embryo is one that has extra or missing copies of chromosomes. Nowadays, we know that aneuploid embryos are frequent, and this depends on maternal age, among other factors. For instance, around 25% of embryos of 30 years old women are aneuploid, and this proportion is increased until 50 at 40 years old. Aneuploid embryos are not compatible with life, so the vast majority of them miscarry or do not implant. During in vitro fertilization techniques, we can choose the best embryo based on its morphology, but it may be aneuploid, and there's an increased risk of implantation fail, miscarriage, or even having a child with a chromosomal abnormality. Taking this into account, the only way we have now of avoiding aneuploid embryos is by performing genetic testing at preimplantation stage in order to determine embryoploidy. PGT, or preimplantation genetic testing, is a group of techniques used to identify genetic defects in embryos created through IVF before pregnancy. It was clinically applied for the first time 28 years ago. PGT allows to select those embryos that are free for certain genetic alterations prior to implantation. There are three types of PGT. The first one is PGT-A, that it is used to screen for chromosome abnormalities, so it allows to select euploid embryos. Then we have a PGT-M, used in case of couples that are at risk of having a child with an inherited disorder caused by mutations in a single gene. And finally, PGT-SR, that it is used for couples that one or both of them have a balanced chromosome structural rearrangement. In this presentation, I'm going to talk about the first type, PGT-A, as it is the most common used PGT type. PGT-A is especially used in case of advanced maternal age, recurrent miscarriages, and recurrent implantation failure, among others. PGT is done 3 to 5 days after fertilization, and the first step is doing an embryo biopsy. That means that we have to remove one cell or several cells from each embryo. Then these samples are analyzed in a laboratory in order to identify which ones have a correct chromosomic load. The genetic technique that is now used for performing the genetic analysis of PGT is called NGS, or next generation sequencing. Once the results are obtained, those embryos that have a greater chance of giving rise to a pregnancy are selected. Usually, these embryos are transferred to the maternal uterus one at a time. The most important step of preimplantation genetic testing is embryo biopsy. It may be done at day 3 after fertilization, where the embryo is at the 6 to 8 cell stage. In this case, the embryo surface, called zona pellucida, is opened, and one cell called blastoma is removed for analysis. But the majority of PGT is now done using blastocyst biopsy at day 5 after fertilization. This is a blastocyst stage when the embryo contains around 100 cells. As we can see in the picture, blastocyst consists of an inner cell mass which will eventually give rise to the different structures of the fetus, and an outer layer of the outer layer of the blastocyst called trophectoderm, which will eventually become the placenta. This layer surrounds the inner cell mass and a fluid-filled cavity known as blastocell or blastocyst cavity. Surrounding the embryo, there's another layer called zona pellucida, as we have seen previously. In this case, a small group of cells is taken from a part of the trophectoderm that, as I have mentioned, will become the placenta. The main advantages of blastocyst stage biopsy compared to day 3 biopsy are that we can obtain more genetic material, as we are taking a group of cells, not only one, and also as the embryo contains more cells and only a small group is taken from the trophectoderm, blastocyst stage biopsy is less detrimental. Moreover, it allows the detection of mosaicism, as we will see later. Nonetheless, in this case, embryo vitrification is required. As every technique, PGT has some benefits and limitations. Among benefits, comparing to IVF cycles where no PGT has been done, we find that it improves implantation rates, reduces miscarriage rates, improves ongoing pregnancy rates per transfer, and also it reduces the risk of having a baby with a chromosomal abnormality. On the other hand, it has some limitations. It is a complex technique that requires investment in highly trained personnel and specific equipment, especially because of the embryo biopsy. It is an invasive method in which the vast majority of embryos survive the biopsy. Also, there is a small chance that an embryo could arrest after the biopsy is performed. And finally, the possibility of misdiagnosis due to embryo mosaicism. Mosaic embryos are formed by a combination of euploid and aneuploid cells that can be distributed in different ways. They are a common finding in PGTA. In this picture, we can see 3 different types of mosaic embryos. In the 2 first cases, the embryo biopsy is not representative of the inner cell mass, so it will lead to a misdiagnosis. And in the 3rd case, the diagnosis will depend on the zone where the biopsy is performed. More recently, the discovery of cell-free DNA into the embryo and its environment has given rise to a new technique in the field of PGT, the non-invasive preimplantation genetic testing, that it has been expected to overcome some of the limitations of the traditional PGT. In 2013, it was reported that detection of embryo DNA in blastocell fluid, the fluid inside the blastocell cavity of the blastocyst. Several studies supported blastocell fluid aspiration as a promising non-invasive alternative method to obtain information of chromosome load of the embryo. Nevertheless, although the aspiration of blastocell fluid is less invasive than trophectoderm biopsy, it is still not completely non-invasive. Later, in 2016, embryonic cell-free DNA was detected in spent blastocyst medium and was proposed as a completely non-invasive tool for PGT. This DNA is released into the culture medium during in vitro embryo development by mechanisms that are yet unclear. In the last years, several studies have demonstrated their capability to detect, extract, and amplify DNA from spent culture medium, especially at blastocyst stage, and has investigated its potential clinical application for non-invasive PGT. And how is non-invasive PGT performed? In this case, the protocol is much simpler than invasive PGT because we are avoiding embryo biopsy. Although there are some variations between laboratories, the basic steps are as follows. First, on day 4 after fertilization, each embryo is washed and transferred to a new individual drop where they are incubated until day 6. During this period of time, the embryo releases cell-free DNA to the medium. Then on day 6, embryos are vitrified, and then the spent medium is collected and analyzed by NGS in order to detect this cell-free DNA and identify possible aneuploidies. But does non-invasive PGT work? Nowadays, there is a lot of controversy about success rates of non-invasive PGT. In this slide, we see the reported results of different groups as an example. The reported informativity rates in terms of successful detection of cell-free DNA and interpretable results range between 80 and 100%. These high informativity rates are due to the fact that the spent culture medium is collected at day 6 when there is enough amount of released DNA. Regarding to concordance rates between non-invasive PGT using spent culture medium and trophectoderm biopsy, they vary widely. In the first 2 studies, high concordance rates of almost 90% have been reported. In fact, this concordance rate is even higher when comparing non-invasive PGT and whole blastocyst results, suggesting that DNA released by the embryo could be more representative of whole embryo chromosomal status than trophectoderm biopsies. In these studies, authors assume that these high concordance rates were due to the optimization of IVF protocols, such as minimizing maternal DNA contamination through successful removal of cumulus cells of eggs in preparation for intracytoplasmic sperm injection, or reducing the volume of culture medium where the embryo is incubated until day 6 in order to concentrate released DNA. On the other hand, there are other groups that have reported lower concordance rates between non-invasive PGT and trophectoderm biopsy between 45 and 65%, or whole blastocyst. It is thought that these lower concordance results are mainly due to the presence of maternal DNA in the spent culture medium, and other possibility is the existence of mosaic embryos whose embryo biopsy may not be representative of the rest of the embryo. Regarding to benefits of non-invasive PGT, we can find that it avoids invasiveness and potential embryo harm. There's no need for embryo biopsy training. It reduces equipment and personal expenses, so it increases accessibility to a wider population of patients. And some concordance rates are very high, as we have seen, especially between non-invasive PGT and whole cell blastocyst, and when optimized protocols are used. suggesting that DNA released by the embryo could be representative of the whole embryo chromosomal load. However, it also presents some limitations. First, the origin of the cell-free DNA remains unclear. There's a hypothesis that states that cell-free DNA secretion is a physiologic phenomenon for each embryo, independent of their quality or ploidy status. But for others, aneuploid cells are selectively eliminated from the embryo as a mechanism of self-correction, resulting in enrichment of the spent medium with DNA derived from these aneuploid cells and increasing the risk of a false positive diagnosis. Moreover, studies remain conflicting regarding whether the released DNA can truly represent the chromosome composition of the full embryo. Also, the possibility of maternal cell contamination that can lead to misdiagnosis is a concern that needs to be solved. And finally, non-invasive PGT needs to be validated in each laboratory, which involves the optimization and standardization of culture conditions and medium retrieval protocols in order to obtain enough quantity of cell-free DNA and avoid maternal cell contamination. This also includes having a successful vitrification program. Today, non-invasive PGT is a controversial technique, as some authors defend its clinical use and others claim that it has serious limitations that need to be overcome before its clinical application. Today, it is used in some clinics as a prioritization system to rank embryos with higher chances of being euploid and therefore decreasing miscarriage and increasing live birth rates. In fact, successful pregnancies using non-invasive PGT and healthy live births are already reported. As mentioned before, it has some limitations that need to be solved, but when overcoming them, it may become a method to complement or even replace the current invasive PGT. To conclude, we can say that non-invasive PGT is a new method to assess embryo chromosomal load without biopsy. It has some limitations that are expected to be overcome in the near future, and for that it requires validation and optimization of IVF protocols in each laboratory. It's a promising method with great potential. And going back to the question of the beginning, can we forget about an embryo biopsy? For me, the answer is not yet. I think this method could replace embryo biopsy, at least in some cases in near future, but some limitations have to be overcome before. And thank you for your attention.
Thank you so much indeed for that wonderful presentation. You've provided lots and lots of details as well, so thank you so much. It's been definitely interesting and useful. And of course, right now it will be time for your questions. So as always, remember, if you would like to ask anything, go ahead, type those in. Estefanía is right here to help you out with any of those. And of course, we also can start with the, okay, yeah, Marta is right here with you, right?
Yes, Marta.
Excellent. We have Marta. She is here to support us. She is the coordinator as well at Vistahermosa. So thanks so much, Marta, for being with us here tonight as well. And let's get going with our questions then, okay? So the first one is right here. If you can explain further PGT-SR.
Yes, well, PGT-SR, it's a type of PGT that is used for patients that have structural rearrangements in its karyotype. and it's used to avoid that these structural rearrangements are inherited by the children.
And thank you, of course, for that very first question, Angela. I hope that that is what you wanted to hear. If you have any other follow-up, of course, you can type person. Yeah, sorry, there is one follow-up. Do you mean due to genetic issues? It's a follow-up from the previous
Yes.
question.
Yeah. Well, it's due to structural rearrangements in the karyotype, like translocations that are when there's a part of a chromosome in another chromosome. So this could lead to chromosomal defects in the children,
the offspring.
In the offspring, yes. Thank you, Marta. And so this PGT type is used to avoid this.
All right. Thanks so much for explaining this for first question then. And let's have a look. Another one is right here. So what are the main differences between PGT, NGS?
Yes, well, PGT is the preimplantation genetic testing that it consists of a group of techniques to avoid that genetic defects are inherited by the offspring. And in NGS is the genetic technique that is used in PGT to analyze the material, the genetic material. Yes, PGD is
the terminology used
yes,
before.
Yes. Now the terminology is PGT, that it's preimplantation genetic testing, and before it was named PGT, that is preimplantation genetic diagnosis. And NGS is the genetic technique that is used in PGT.
Thank you so much for the clarification. That can be confusing. So PGD is like no longer used. It was used before, right? So now it's PGT. Excellent. Thanks so much. Okay, let's have a look. Yes, okay, sorry. Angela has just asked, just let me show you. So PGTA is the equivalent to PGD used before. Yep.
Yes, that's it.
Thanks so much then, of course. Okay, next question is right here. So does mosaicism issue also exist in non-invasive PGT?
Yes, of course. And also mosaicism can also be detected by non-invasive PGT, non-invasive PGTA. Mosaic embryos are frequent, and so we can detect them when we use invasive PGT using biopsy at day 5, and also at non-invasive PGT because DNA from the embryo is released to the medium, and it becomes from it's supposed that this released DNA comes from many parts of the embryo. So yes, mosaicism can also be detected at non-invasive PGTA.
Thank you so much for that question, and thank you, Estefanía, for explaining as well. Let's have a look. One more question from the very same patient. What is the chance of success with mosaics? Is it like capacity in 30%? Do you recommend to transfer such an embryo?
Well, this is a complicated question because, trisomy 18 It's a Edwards syndrome. So the fully trisomy 18 is compatible with life, and the 30% mosaic, we cannot know what will be the phenotype of this fetus, or if this baby. So there's complicated. It needs to be evaluated in the laboratory.
Understood, of course. Thank you so much. So again, you would just need more details, yes, in order to be able to provide more details about that. Yes? Sure, of course.
Yes, of course. And it also depends on if you only have that embryo or have other embryos. But trisomy 18, you have to be. We have to be careful with this trisomy, because it's compatible with life, the fully trisomy.
Thank you so much, then, of course. Okay, let's have a look. Another question is ready here. Should mosaic embryos be retested? I've heard that they can self-correct during pregnancy.
Yes, and this is a nice question, because this is a controversial topic, and we don't know yet. It's true that there are some hypotheses that say that there are a lot of mosaic embryos, but most of them can self-correct, and finally they become a euploid embryo. Yes, this is a hypothesis, but others say that the self-correction phenomenon is not possible. So we don't know yet clearly. We have to investigate more in this field.
Thank you so much. Indeed, definitely, this is an interesting topic as well, but still we need to wait for more,
Yes.
I guess, more evidence, right?
Yes, more data.
Of course. Thank you so much indeed for that question. There is one more, okay, from Angela. So what is the percentage of women in their 40s to have a euploid embryo that would result in a live birth?
Some studies say that women in their 40s have like 50% of uneuploid embryos, and the other 50% that are euploid. So from the euploid embryos, we don't know if all of them are not going to result in a live birth, of course. Because there are other factors, not only chromosomic load, that affects to the implantation rate. So yes, in women in their 40s, we have around 50% of embryos that are euploid, and the other 50% that are uneuploid.
Excellent. Thank you so much. And Angela has added one more question to this one.
Yes.
What are the other factors?
Yes, thank you, Angela. And other factors, well, many of them we don't know yet. We know that chromosomal load is very important. It's critical. But there are other factors like that depend on the uterus, the endometrium. Yes, also in the male factor, because if sperm is not of good quality, this reduces the chance of pregnancy, of course.
That makes perfect sense, of course. Thank you so much indeed. Okay, someone is typing, and yeah, the question is right here. And we will be slowly finishing because we are coming to an end, as I can see, when it comes to the question. But I just want to make sure that you have asked all the questions. So please, if you have any, go ahead, type those in, and let's have a look at the next question. Is number of cells important in euploid blastocysts? Is size of blastocysts more important or number of cells?
Well, both things. Both things. Size of blastocyst, and also number of cells, degree of fragmentation, the rhythm of dividing these cells. They are all important factors. Yes.
All right. Thanks again, of course, for yet another interesting question. And let's have a look. Okay, someone is typing, so we just need to wait a bit and see whether it is another question. Okay, let's have a look. From Angela, can you please repeat the slide that mentions which part of the embryo develops into fetus, placenta, etc.?
Yes, of course.
I can show you the slides.
Okay, thank you, Caroline.
Just don't remember which one it is, so
yes, I will show it. Don't worry.
Perfect. Excellent. Thanks so much.
Okay. Well, as we can see in the picture, blastocysts consist of an inner cell mass, that is this part, which will eventually give rise to the different structures of the fetus, and the outer layer of the blastocyst called the trophectoderm, that is these cells that are here, will eventually become the placenta. This layer surrounds the inner cell mass, and also a fluid-filled cavity known as blastocell. And surrounding the embryo, there's another layer called zona pellucida, that is this part of here.
Again, thanks so much indeed for explaining, and I believe that was again useful for all of you. And let's have a look. Again, I think that someone was typing, so we need to wait. Yeah, here it is, sorry. Just need to put it right here. So an euploid embryo that has a good size can fail implantation due to the number of cells?
Yes, of course. Well, I think that you are referring to the blastocyst stage, and yes, the number of cells it's important. In the blastocyst stage, we have around 100 cells, and usually euploid embryos have the correct number of cells, but it's possible that this number can vary.
Excellent. Thank you so much indeed for yet another question, of course. At least at this point, I do not see any questions. Yes, there is a thank you, though, of course, for answering. So we will be slowly finishing, okay? But as always, I want to remind everyone that, of course, if you have any more questions now, you can still do it. And if not now, remember that you can get in touch with Estefanía and her team at Vistahermosa, and I'm sure they will be able to help you out. Marta as well, of course, I'm sure. So you can always do that. And I guess we will be finishing for tonight. Although, again, someone is typing, so let's give it a minute. I just want to make sure that we have been able to answer all of your questions, and it is a thank you. So thank you so much indeed, Estefanía, Marta, for being here with us as well. Well, everyone, thank you so much. I do believe that it has been very useful for you. And before we finish, Estefanía, is there anything else you would like to add?
Well, it's a pleasure to be here with all of you, and Thank you for the invitation.
Thank you so much indeed. And let me just remind everyone, as always, it has been recorded. So of course you will have a chance to watch this again. It will be available tomorrow on our site, myivfanswers.com. And if you get in touch with Estefanía, Marta, her team, I'm sure they will be able to help you out with any questions that you might have. And with that, we can finish. Have a lovely weekend, everyone. We will be back on Monday. So I do hope to see you here on Monday. And okay, see you, Estefanía, very soon, I hope, and Marta as well. Okay.
Yes, of course.
Thank you.
Thank you so much. Take care, everyone. Have a lovely evening and weekend. Bye.
Cheers. Bye. Bye.